Good evening, everyone, and welcome to this webinar. This is the second class on the Nclex review on case studies. And the reason that we're doing case studies is because of the fact that in the new generation Nclex, it is now included. There will be 18 questions on case study format. And the purpose of case studies is to elicit your knowledge in making decisions. And there are 6 questions to see whether or not you could recognize cues, you could analyze cues, you could prioritize hypotheses, generate solutions, take action, and evaluate outcomes. So our topic for today, which is the case study, is going to be acute respiratory distress syndrome secondary to septic shock. And therefore, the content of this presentation for the Nclex review for the second day is focused on this particular disorder. So let's begin our discussion with sepsis. What is sepsis? Well, sepsis is a life-threatening medical emergency that is caused by a massively response to infection. So basically, there is a massive overblown response to an infection. And it usually is caused by a bacterial infection, but it can also be due to viral infections such as COVID-19. Now, the most commonly associated with sepsis are E. coli, Staph aureus, and some strains of streptococci. So usually when we have a sepsis, infections that lead to sepsis can begin anywhere in the body. But most commonly, they start in the urinary tract, and that's the most common. They could also start in the lungs, the skin, as well as the GI tract. So because this disorder is a life-threatening organ dysfunction, we are going to assume that this is a high item in the Nclex. So the probability of items coming out in Nclex is going to be very high. And that's the reason why I included this in our case study. So let's further discuss what we need to do or what we need to know as far as sepsis is concerned. You all are familiar with sepsis bundles. And bundles are tools that healthcare organizations can use to guide the implementation of evidence-based guidelines to improve outcomes in the treatment of sepsis and septic shock. So the one thing that is emphasized in this bundle is that the concept that sepsis is a medical emergency that requires immediate and timely intervention. And this is to improve survival not only at the time of presentation, but also during the subsequent hours of entry to the medical system. In fact, since its inception in 2002, the implementation of these bundles has led to more appropriate care in the treatment of sepsis, and therefore resulted in good outcomes and survival. So what are the bundles that are included in here? And let's go one by one as far as the content of this bundle is. And so the first thing is the first hour interventions. What are the responsibilities of the healthcare team whenever you suspect a patient having sepsis? The number one is going to measure the lactate level. And of course, if the lactate level is going to be elevated, then it must be repeated. So what is the value of measuring lactate in the diagnosis of sepsis? While patients with elevated lactate are seriously ill and require effective treatment right then and then. And therefore, measuring lactate levels provides useful information about the progression of the condition and the effectiveness of the treatment. So you might ask, what is lactate? Well, this is a chemical naturally produced by the body, and it fuels the cells during times of stress. Thus, when it's present in elevated quantities, it is commonly associated with sepsis and severe inflammatory response syndrome. So what I want to emphasize here now is that in unstressed patients, the normal value of lactate is 1 to 1.5 milliosmoles per liter. So there's no need for you to write down the value or memorize the value, because as you know, in the new generation Nclex, laboratory values are always going to be mentioned. However, anytime that we have a lactate level of 2 or more milliosmoles, and it is associated with hypoperfusion, then this means to say that the patient is in shock. And so the other parameter is that lactate levels that are above 4 indicates the need for immediate resuscitation and that the patient must be admitted in the ICU. It has been found out that any time a patient has a lactate level over 4 milliosmoles per liter, it is associated with high mortality rate. And that is the reason why lactate is used as a guide for determining the severity of the septic shock that is present in the patient's condition. So the second thing that we must do upon presentation during the first hour is to obtain blood cultures. And this is so that we can administer antibiotics. You all know the rule of thumb, and that is that before administering antibiotics, blood culture should be obtained. And the antibiotics that are usually given are broad spectrum antibiotics. In addition to this, as you could see in number 4, we would want to begin rapid administration of crystalloids for hypotension or lactate levels of above 4 millimeters per milliosmoles, per liter. And then, of course, we could apply vasopressors if the patient is hypotensive during or after fluid resuscitation. And the rule of thumb is we always want to make sure that we maintain a mean arterial pressure above 65 millimeters of mercury. So I want you to remember that number. We would like to maintain an MAP, or a mean arterial pressure, of 65 millimeters or greater. Okay, so the MAP target, mean arterial pressure, is going to be 65 millimeters of mercury. All right, we'll talk more about how you calculate MAPs later on, but this is emphasizing the responsibilities of the healthcare team during the first hour of presentation. All right, so here's the question. Physiologic responses to all types of shock include the following except. Okay, could you please type in the chat box your responses? All right, physiologic responses to all types of shock include the following except. Okay, so be very careful with that particular word, except. We're looking for a physiologic response that would not be typical of patients in shock. All right, your answer? Anybody? All right, so whenever we have a shock, there's going to be an activation of the inflammatory system. What does not happen is letter D. So the correct answer here is vasoconstriction. Now, why vasoconstriction? Well, what happens is actually vasodilation, not vasoconstriction. And it occurs because of the body's immune response. Option A, activation of the inflammatory system, occurs as a response to the invasion of microorganisms. And option B is also correct because there's activation of the coagulation system, because whenever there is shock, there's going to be pro-inflammatory and anti-inflammatory substances that are released. And option C also is going to occur as a result of vasodilation. Okay, so letter D is the correct response. All right, because the word except, okay? So remember that in shock, there is going to be vasodilation, and that is the reason why you have hypotension. Okay. Let's take a look at the next question. A patient is treated for septic shock. Which findings demonstrate treatment is not being successful? Select all that apply. So we're looking for not being successful. All right. Give me your answers. Remember, this is a select all that apply. In the new generation Nclex, the good thing about select all that apply now is that it's right minus wrong. In the past, the scoring was quite different, but now if you got something correct, it's right minus wrong. All right. Okay, so letter A, the mean arterial pressure of 40 millimeters of mercury, as I said earlier, is going to be low. All right. The other thing is that when you answer this question, always select the options that would indicate that the body's organs or tissues are not being perfused adequately. So letter A, for example, an MAP should be 65 or greater for proper tissue perfusion to occur. The other thing is that urinary output should at least be 30 mLs per hour. So again, this is correct. Letter B is a correct response. Serum lactate should be less than 2 milliosmoles. This one is high. If it's high, what does it indicate? It indicates the cells are not receiving enough oxygen due to the low tissue perfusion. So letter C is also correct. A CVP should be greater than 2 millimeters of mercury. Now, if it's less than 2 millimeters of mercury, then this shows that the filling pressure in the right side of the heart is going to be low. So if this number is low, there's not enough fluid that is filling the heart to maintain the cardiac output. So this occurs in septic shock because of hypovolemia. And why is there hypovolemia in septic shock? Well, because of increased permeability, wherein the fluid shifts from the intravascular to the interstitial space. So this is correct. So let me just explain that a little bit. So you have a black screen now because I'm going to illustrate something. Now, if you think about it, if blood vessels are going to be semi-permeable, let's say the blood vessel is this thick, and now you dilate this. When you dilate something like a rubber band, do the walls become thicker or thinner? Do the walls become thicker or thinner? They become thinner. So therefore, if they're now thin, what happens is that it allows for the permeability is now increased, and therefore it allows the escape of fluid from the vascular space to the interstitial spaces. And that is the reason why there is going to be a decrease in your central venous pressure or CVP. Okay, so the correct answers are A, B, C, and E. You're correct, Rihanna. All right. Let's move on to the next question. A patient post-op GI surgery presents with a temperature of 103.6, a heart rate of 120, a blood pressure of 72/42, with increase in WBCs and respirations of 21. An IV fluid bolus is going to be ordered, which findings indicate that he is progressing to septic shock. Select all that apply. All right. So what are the signs and symptoms of shock? Could you please indicate your responses in the chat box? Okay, very good. All right, so let's take a look at the answers. The answers are A and C. So let me just mark that for the benefit of the others, okay? To know if the patient is progressing to septic shock, what you need to know is to think about the findings that are associated with this condition. So septic shock is characterized by hypotension, usually defined as a blood pressure systolic of less than 90. And this usually do not respond to IV fluids. And of course, the patient needs vasopressors like norepinephrine to maintain a mean arterial pressure that's greater than 65. So this is going to be a correct response. A central venous pressure CVP of 18 is high, actually. So again, whenever we're measuring CVP, it actually is going to be between 8 to 12 is the normal millimeters of mercury. So let me just write that down. Is 8 to 12. Now, CVP could be measured by centimeters of water as well. So the centimeters of water value is going to be a, 4 and 12 centimeters of water. Okay, so those are the values for a normal CVP. And so this one, a central venous pressure of 18, is going to be high. All right. Okay, let me just pause to see if you have any questions. You know, there's only 5 of you. So we have the opportunity to have a discussion, if you will, whenever you have a question. So please feel free to interrupt me anytime that you do have a question. Okay. All right. So that's the discussion on septic shock. Let's now go to a discussion of ARDS, which is another condition. And usually this is an offshoot of the septic shock. So what is ARDS? Well, ARDS stands for Acute Respiratory Distress Syndrome. This is a life-threatening lung injury. And the reason why this is a life-threatening injury is because of the fact that when you have an ARDS, fluids leak into the lungs. And if fluid leak into the lungs, breathing becomes more difficult and oxygen cannot get into the body. So this is a case or a condition that has a high mortality. And therefore, it is one of the complications of septic shock that we need to pay attention to. So let's discuss a little bit about the pathophysiology of why fluid will now leak into the lungs. So let's go back to the alveoli. You know, when we have an alveoli, the average person has close to 500 million alveoli in the lungs. Each of these are responsible for performing two critical tasks. What are the responsibilities or the functions of the alveoli? One is to transport oxygen into the blood in the capillaries. And the second one is, of course, to remove carbon dioxide from the blood. So think about those two tasks that are critical to perform. And therefore, when you drown the alveoli, they are not able to do these functions. So when we take a close look at the alveoli are lined by two types of epithelial cells. And these are called pneumocytes. Type 1, these allow oxygen and carbon dioxide to pass through them. And then the other type of pneumocytes, or type 2, are those that produce surfactant. And what is surfactant? Surfactant is a very important element that is present in the alveoli. This is an oily secretion, and its function is to coat the alveoli and prevents their collapse. So, in addition to interfering with the ability of the alveoli to exchange oxygen and carbon dioxide, when it is compromised, you also have to think about the surfactant that is going to be involved. So when you have damage to the alveoli and the neighboring capillaries, it reduces the ability of the lungs to send oxygen into the blood. This happens because the lung injury causes fluid to leak into the spaces between the capillaries and the alveoli. So why again is the fluid going into the alveoli? You remember that stretch rubber band? The walls of the capillaries are going to be stretched, and therefore they allow for the migration of fluid to leak into the alveoli. So when you have fluid going into the alveoli, what's going to happen? The pressure on the alveoli increases, and this is what gives ARDS its characteristic trait: the accumulation of fluid in the lungs, causing the alveoli to collapse. And so this is what happens exactly when we have a patient that would have ARDS. So let's take a look at the relationship of sepsis to ARDS. So I said earlier that sepsis is going to result when an infectious insult triggers a localized inflammatory reaction. So this is the precipitating event, is that there is bacterial invasion. This causes endoxins to be released, And therefore, inflammatory processes are going to occur. And this causes damage to the lungs, which in turn causes damage to the alveolar epithelium, as well as the capillary epithelium. And when this happens, there's going to be vessel leak, and therefore it leads to pulmonary edema. Pulmonary edema, in turn, would result into hypoxia, and hypoxia will further cause pulmonary vasoconstriction. So all these are going to be related to manifest all the signs and symptoms that are associated with ARDS. So you might be wondering, what are the causes of lung injury that lead to ARDS? Well, we actually divide them into two broad categories. One is what is known as direct lung injury, and the other ones are indirect lung injury causes. So what are direct lung injuries? They are those that occur in or directly affect the lungs. So examples of that might be pneumonia, for example, aspiration, inhalation of toxic substances, trauma. Another one would be near drowning, as well as embolism. And then, of course, we have the indirect lung injuries that causes ARDS. And an example of that might be sepsis. That's number one, or severe trauma to the body. Massive blood transfusions, for example, and pancreatitis are all things that occur in the outside, yet they involve the lungs in the long run. Out of these possible causes of lung injury, two of them, sepsis and pneumonia, that's why there is a asterisk mark after them, make up majority of all ARDS cases. Okay. All right, so now I have another question here. The lung cells that produce surfactant have become damaged. As the nurse, you will know that this will lead to what? So what happens when there is damage to the surfactant? Your answer? Thank you, Francis. All right. So the correct answer is atelectasis. And let's see why it's atelectasis. Whenever you have a decrease in surfactant, there's going to be, therefore, an increase in the tension in the lungs, because you remember surfactant decreases tension in the lungs. So it prevents atelectasis or collapse. Therefore, when this happens, the alveoli sacs will stay stable when a person exhales. So this means to say that with surfactant, the sac won't collapse. Whenever there's a decrease in surfactant production, there's going to be a collapse of the alveoli, and this condition is what's called atelectasis. So the correct answer is letter B. Let's now go to the symptoms and the clinical presentation of a patient with ARDS. The first symptoms of ARDS usually develop within a few hours of, or even up to a week after lung injury. In the early stages, the signs and symptoms are going to be hard to detect. At first, the fluid is leaking in the interstitial spaces of the lungs. So lung sounds may be normal, or maybe you might hear a crackle here or there. But as it progresses, the patient will have difficulty in breathing and will demonstrate air hunger. So there will be an increase in respiratory rate, there's going to be low oxygen in the blood, and there's going to be respiratory alkalosis. So remember that the early stage is going to be characterized by respiratory alkalosis. And the reason why I wanted to emphasize that is in the late stages, what's going to happen is it's going to change. All right. So what are the late findings as far as ARDS is concerned? Well, you will have tachypnea, you will have difficulty of breathing, you will have hypoxemia, even though maybe the patient might be receiving a high amount of oxygen, and this would be called refractory hypoxemia, when the patient's oxygen state is going to be compromised. And this could also be associated with low oxygen saturation as well as mental status changes. The patient might get confused. They might get exhausted or tired. Tachycardia is going to be present, and there's going to be a decrease in the lung compliance. So if this is left untreated, what's going to happen is that you're going to have, of course, hypotension. So these are the progressions of the symptoms of ARDS. All right. Could you select all the indirect causes of ARDS? Indirect. Okay, so whenever we're saying indirect causes, these are processes that causes inflammation outside of the lungs. So the issue arises somewhere outside the lungs. So the correct answers, therefore, are C, this is outside of the lung, D, blood transfusion, and then, of course, E, pancreatitis. Okay. Drowning directly affects the lungs, and aspiration, of course, directly affects the lungs. So these are direct causes of ARDS, not indirect causes. All right, so let's delve further into the physical examination findings that you will find in a patient with ARDS. They usually are going to be non-specific as well as include the manifestations associated with respiratory distress, namely tachypnea or fast respiratory rate, tachycardia, and the need for a higher amount of oxygen. So the amount of oxygen that we give to the patient is termed FiO2, or the fraction of inspired oxygen. Fraction of inspired oxygen. So what is your FiO2 right now, for example? What is your FiO2 at the moment? All right, we all breathe 21% of oxygen from ambient air, or 20.88 to be exact. And so our FiO2 is 21%. Obviously, when you give patients oxygen, the FiO2 is going to be increased. So you might be giving them, for example, 60%, 30%, 50%, and so on. So that is what is known as the FiO2. So in patients with ARDS, the need for a higher fraction of FiO2 in order for them to maintain an oxygen saturation within the normal range. And then, of course, the patient may be febrile or hypothermic. Now, this is something that some people do not understand. Why would there be hypothermia if there's a lot of infection? Well, in sepsis, because of all the inflammatory mediators that are released, what happens is that the temperature control regulation of the hypothalamus is going to be messed up, and therefore the patient may be hypothermic. Okay, so just because a patient doesn't have a fever does not mean to say that they do not have any infection. So in fact, you could be hypothermic and have sepsis. All right, and the other thing is, of course, hypotension as well as peripheral vasoconstriction. And when you have peripheral vasoconstriction, what happens to the temperature of your extremities? They are going to be cold. So their cold extremities may be present and even result perhaps in cyanosis of the lips and nail beds is a possibility. Bilateral lung ralphs are going to be, of course, a finding that you will have on auscultation of the patient. All right, so let's take another question here. A patient with aspiration pneumonia is on 100% non-rebreathing mass. Which finding below is a hallmark sign that ARDS is developing? Your answer? Thank you, Francis. All right. The answer is letter C. Remember what we said about refractory hypoxemia? This is the hallmark sign and symptom in ARDS. This is where that although the patient might be receiving a high amount of oxygen, here a 100% non-rebreathing mask, the patient is still hypoxic. So option C is the answer. And of course, the patient can be tired and confused from a low oxygen level, but this question wants to know the hallmark sign. So this is the critical word in the stem of the question. Okay. All right, here's another question. Which statement by a new nurse demonstrates he understands ARDS? All right, so your answer is letter D. Very good. This is the correct answer. This condition develops because alveolar capillary membrane permeability has changed, leading to fluid collecting in the alveolar sac. All right, so letter B describes COPD. This is not ARDS. Obstruction, meaning to say this is going to be COPD. And that's the reason why that is not the correct answer. And then, of course, letter C refers to pneumothorax. And obviously, then the correct answer is letter D. All right, so what are the diagnostic markups for or workup for these patients? Well, in order to have a diagnosis of ARDS, we have to base it on some criteria. And so these criteria includes, the acute onset as well as bilateral lung infiltrates on chest X-ray. So therefore, that is the finding that you will see. And the other finding that is going to be consistent with the diagnosis of ARDS is going to be a PaO2 or an FiO2 ratio of less than 300 millimeters of mercury. So let me just explain this PaO2 and FiO2. All right, if you are, let's say, having difficulty of breathing, and I do your blood gas, and let's say now that your PO2 is going to be 90. So let's take an example. So supposing your PO2 is going to be 90 millimeters of mercury, and you are having an FiO2 or oxygen that's being given to you at 40%, okay, the ratio is going to be 225. So how did I get 225? Well, 90 divided by 0.40 is going to be 225. So this illustrates that the oxygen is not doing its function because of the damage that has occurred. So anytime you have a PaO2 FiO2 ratio of less than 300, then that means to say that there is going to be a decline in the ability of the alveoli to do its function. All right? The other diagnostic workup would be bronchoscopy as well. And this would be to assess pulmonary infections. And sometimes we do this in order to obtain material for culture. Other laboratory tests will include CBC with differential. And the reason that we would like to have the CBC with differential is obviously going to find out the degree of immune system response. A CMP, or a comprehensive metabolic panel, also is going to be valuable in order for us to determine if there are other abnormalities that might affect not only the progress of the patient, but also the treatment. A coagulation panel, as well as troponin and ABG, is also going to be included in the diagnostic workup of the patient. All right, so what are the interventions that we should anticipate for patients that are experiencing ARDS? Well, we're guided by 5 Ps, and the 5 Ps of management of patients that undergo or are experiencing ARDS includes the first P, which is perfusion. So we want to maintain the goal for ARDS is to maximize perfusion in the pulmonary capillary system. And how do we do this? By increasing the oxygen transport between the alveoli and the pulmonary capillaries. So in order to achieve this goal, what do you need to do? You need to increase fluid volume without overloading the patient. So therefore, when we give crystalloids or colloids to replace the fluids that have leaked from the capillaries into the alveolar spaces, we need to be careful that we are not overdoing it. So what can we do in order to monitor the effectiveness of our therapeutic interventions with fluids? We could monitor the CVP, or we could insert a PA or pulmonary artery catheter in order to monitor the responses, the hemodynamic responses of the heart. Now, blood transfusions actually could also improve delivery. But remember, they can also cause an increased inflammatory response and therefore increase the risk of infection and death. And thus, it is not an ideal way to increase your perfusion. So the other ways in which we could maintain perfusion is to use inotropic agents. So what is inotropy? Inotropy or inotropic agents are agents that improve contraction. So inotropy has something to do with myocardial contraction. So if we say that we have a positive inotropic agent, these are the examples of positive inotropic agents. They increase the force of cardiac contraction. Dobutamine or Wtrex can increase cardiac output, and therefore by doing so, you could boost oxygenation. Milrinone, which is also known as Primacor, is another inotropic agent that improves perfusion by causing vasodilation in the pulmonary bed, okay, only in the pulmonary bed. And therefore, these are going to be adjuncts to manage the perfusion of the patient. Vasopressors, such as norepinephrine and dopamine, are going to be agents that promote systemic vasoconstriction. Thus, when you constrict the blood vessels, what happens to blood pressure? You increase the blood pressure. You also, therefore, increase perfusion. Now, it's important that when we are giving vasopressors, we need to monitor the vital signs, the temperature of the patient, and of course, the patient's tolerance to the therapeutic intervention. So that's the first P as far as management is concerned. Now, the other thing that we need to do is to make sure that we maintain the oxygen status of the patient. So because mechanical ventilation or intubation, as well as mechanical ventilation, may be associated with an increased incidence of complications, alternatives to mechanical ventilation, such as a high-flow nasal cannula, or maybe CPAP or BiPAP, may be beneficial in patients with ARDS. So whenever we have a high-flow nasal cannula, we're using actually heated humidification, and therefore we could increase the flow of oxygen by as much as 50 to 60 liters per minute. So this is usually used in conjunction with a heater or oxygen blender, and therefore it allows for a precise delivery of inspired oxygen concentrations. Okay, so these are some of the ways in which we could maintain the oxygenation of the patient. Okay, here's another question to see whether or not we are awake. A patient with a near drowning event has a respiratory function deteriorating over the last 24 hours. What finding on the chest X-ray is indicative of ARDS? Your answers? Anybody else? Okay, so letter C, Marcellus is correct. Letter C is the correct response. Whiteout infiltrates bilaterally. This is a finding found in ARDS. a pronounced whiteout infiltrate that usually is bilateral. All right, so sometimes when we treat patients with ARDS and all the other measures fail, what we now have to do is to intubate the patients. The unfortunate thing is that we have to do this because of the persistent hypoxemia of the patient. So what are the goals of mechanical ventilation in ARDS? Well, the goal is to maintain oxygenation, but we have to avoid oxygen toxicity. Oxygen can be poisonous to the patient and the complications of mechanical ventilation. So what do I mean by oxygen creating some toxicity? Okay. So when you look at the alveoli, right here, when we breathe, it expands. And when we exhale, it remains inflated. It does not, contrary to what you might think, collapse like this. No, because of the presence of surfactant, number one, and the major reason why the alveoli remain open is because of physiologic PEEP. PEEP stands for positive and expiratory pressure. The major reason why these alveoli do not collapse is because of the presence of nitrogen in the atmosphere. Now, if you look at room air, what do we breathe actually? We breathe 20.88% or 21% of oxygen. 78% of ambient air is actually nitrogen. And then, of course, the 1% is other gases. So this is 100% room air. So why is it that in the atmosphere, there is an abundance of nitrogen? What is the function of nitrogen? The very important function of nitrogen in ambient air is to allow for the alveoli to remain inflated for a long period of time, and it does not collapse. And that's the reason why whenever you're going to go dive, what happens is that the nitrogen is going to be much more. You're going to develop pulmonary edema because you could have a rupture of your alveoli. So, having said that then, whenever we are giving a patient oxygen that is going to be over 78%. So let's say that we are giving oxygen at 100%. What happens when you give oxygen 100% to a patient? Nitrogen is only 78%. Do you remember? So which one is going to enter into the alveoli? Is it going to be oxygen or nitrogen? More of the nitrogen more of the oxygen is going to go in here and it washes off the nitrogen. So when you wash off the nitrogen, what happens to your alveoli? What happens to your alveoli when we increase the oxygen to 100%? Hello? No, you remember? So this is oxygen at 100% versus nitrogen, which is 78%. So this is the alveoli. Which one would go, oxygen or the nitrogen? This is stronger. So the oxygen is going to come here and the nitrogen is going to be washed off. And therefore, when you don't have nitrogen in the alveoli, what's going to happen to the alveoli? What's going to happen to the alveoli? It's going to collapse. Yes, very good. Okay. So going back to the slide now, before we go to a break, whenever we intubate a patient, we would like to make sure that we do not give too much pressure because of the fact that we might rupture the alveoli. So we want to maintain the tidal volume from anywhere from 4 to 8 millimeters per kilogram of body weight. So usually, whenever we intubate patients, the way that we determine the tidal volume is the amount of air that you're going to be delivering over to the patient. So how much air do you want to give the patient? That's the tidal volume. And usually we calculate that to around 10 mLs per kilogram of body weight. So if you're 70 kilos, how much tidal volume do we usually give you? If you do not have ARDS, we would give you 700 mLs for tidal volume. But in patients with ARDS, we're conscious of the fact that the lung protective protectors, such as your surfactant, as well as your nitrogen, is going to be blown off when you give too much. So we only give approximately 4 to 6 mLs per kilogram of body weight. Okay, so in a patient who is 70 kilos, we would give them 7, 14, 21, 28, 280 mLs rather than the 700 mLs of tidal volume. Okay, do you understand tidal volume now? Tidal volume is the amount of air that you're going to blow into the lungs of the patient. So in patients with ARDS, we are careful to decrease that tidal volume. And we usually are going to apologize, it's 4 to 8, not 4 to 6, 4 to 8 mLs per kilogram of body weight. All right. Okay, so it's now 7 p.m. and what I'd like to do is to give you a 5-minute break because I don't want to over talk and bore you. And so let's take a 5-minute break and then come back and continue with our discussion. Thank you so much. Okay, welcome back. I hope you had the opportunity to respond to your physiological needs. But now let's go back to what we were talking about. And we were talking about the ventilator management of patients with ARDS. And so I wanted to go back a little bit to some terminologies because I might have lost some of you, particularly if you haven't had any rotation in the critical care units or in patients that have been on a ventilator. But whenever we have a patient on a ventilator, we have some settings that are going to be pertinent in this discussion. So vent settings that are important would be the respiratory rate. Well, this is self-explanatory. So we may have the respiratory rate at some numbers. So let's say 18 or so, that would be the respiratory rate. The other thing is the FiO2, and I already discussed this. This is the fraction of inspired oxygen. So this is the percentage of oxygen that the patient is receiving. So it's always expressed in percent. Now, remember that in ARDS, we do not want to use any oxygen that's greater than 60% as much as possible. So if you take a look at this slide, we want to maintain the FiO2 to around 50 to 60%. And again, I emphasize to you that the reason why we don't want to go beyond 60 is because of the fact that when you reach and compete to the nitrogen percentage of 78%, you wash off the nitrogen, and therefore it results into lung collapse. And the last thing is PEEP, positive and expiratory pressure. I explained what physiologic PEEP is. And physiologic PEEP is different from mechanical PEEP. And physiologic PEEP is the fact that when we exhale, the alveoli remains open. And the reason why God created it this way is so that it will allow for longer exchange of oxygen and carbon dioxide. So that's the reason. The longer the alveoli is open, it's thin, it's going to facilitate the exchange of oxygen and carbon dioxide. So PEEP could be physiologic. So the physiologic PEEP means to say that this is a function of nitrogen. The other one is mechanical PEEP. This is when we add more pressure so that we can prolong the expansion of the alveoli. And in patients who are on ventilators, we could do that by increasing the settings, and we usually do it with increments of 5 millimeters of mercury. And that is the one way in which we are going to, centimeters of water, I should say, one way that we could improve oxygenation. Now, the consequence, though, of mechanical PEEP is that it usually causes hypotension, right? So always remember that. PEEP, artificial PEEP or mechanical PEEP causes hypotension. Why is that? Let's try to find out why that is, or explain why it is. So the lungs, there are two lungs, obviously, and the heart is right over here, okay, in the middle. Now, if we're going to prolong the expansion of the lungs, what's going to happen is that this is going to be expanded for a longer period of time. What happens to the heart? The heart is squeezed, and therefore, this is going to cause decrease in cardiac output. Okay, so one of the consequences then of PEEP is that it might cause, or it will cause hypotension, and therefore will worsen the hypotension that's already present. Okay, so that's the lung ventilation management of patients with PEEP, with ARDS. Now, the other thing that has been found out to increase the oxygenation is positioning. In particular, prone positioning of the patient with ARDS improves what is known as the ventilation-perfusion ratio. Whenever we put a patient on the prone position, aeration improves because the heart no longer compresses the posterior areas of the left lung as what it does in the supine position. So when the patient is prone, most of the lung tissue, which is in the posterior areas, by the way, moves towards the anterior, and therefore clearing the airways of debris. It decreases atelectasis, reducing lung inflammation, and therefore produces a more efficient oxygenation and perfusion. So this is very important, that we are going to position the patient in a prone position. And this is usually a challenge because if the patient has a ventilator, it usually is going to be very difficult to move them from the traditional supine position to a prone position. So although this process is very, it requires a lot of planning and labor intensive, it requires special training and the use of special beds also. But prone positioning is believed to improve ventilation perfusion ratios. All right, here's a question. The patient with ARDS is ordered ABGs, which is expected during the early phase, correlating with the diagnoses. So in this particular question, we're being asked about the ABG that you would notice on a patient. Okay, can you give me your responses, please? All right, so in the early stages of ARDS, what happens to your PO2? Your PO2 is going to decrease. Now, what happens to the respiratory rate? Is the respiratory rate going to be normal, fast, or is it going to be slow? Fast, okay. So when you have a fast respiratory rate, because that's what is in the early stages of ARDS, what's going to happen to your PCO2, or your partial pressure of carbon dioxide? You're going to have a decrease in your PCO2, correct? All right, so this is what you need to remember in order to answer this question. So over here, it says 40, 85 of PaO2, PO2 of 50, PO2 of 55. So we could eliminate this because this is high, right? I mean, it's technically the highest among them. So that would not be it. The second thing that you would now take a look is that if the PCO2 is going to be decreased, what's going to happen to your pH? Your pH is going to be high. It will be alkalotic. All right, a pH of 7.9 is alkalotic. A pH of 7.42 is normal, because you remember 7.35 to 7.45 is normal. 7.20 is acidic, and 7.26 is acidic. Okay, so this might be okay. So let's take a look at the PCO2. Remember, we need a decreased PCO2, so this is good. CO2 of 37, 35 to 45 is normal. And CO2 of 48 is increased, and 58 is increased. So the correct response here is letter A. All right. Honestly, tell me, did you understand how we went about in selecting the arterial blood gas that is going to be reflective of the early stage of ARDS? Do you want me to repeat or to briefly talk about ABGs? Are you all okay? All right, very good, Marcellus. Great. All right, good. Thank you, Rihanna. All right, so let's move on then. Going back to management, the other ways in which we could deal with patients who are severely compromised as a result of ARDS might be the use of extracorporeal membrane oxygenation, or ECMO. This has become increasingly accepted as a therapy for severe respiratory failure, not only as a result of this condition, but a variety of conditions, including ARDS. So the value of ECMO is that it provides respiratory or cardiorespiratory support for lungs that are failing, or heart that is failing, or perhaps both. So this is where you actually would oxygenate the blood flowing through an oxygenator. So this is ECMO, or extracorporeal membrane oxygenation. I'm sure that if you were at the height of COVID, a lot of patients have had to be oxygenated this way. All right, which findings indicate that the prone positioning was beneficial for your patient with ARDS? Select all that apply. Okay, so select all that apply. All right, so improvement in lung sounds, that's very good. I think so. prone positioning helps improve not only your PaO2, but it also improves perfusion and ventilation. So the heart in this position is no longer laying against the lungs, and this improves airflow. So letter A is correct. Development of a VQ mismatch, this is what we're trying to correct. So this would be incorrect. The PaO2 increase from 59 to 82. This is a correct response. The improvement of 82 is a good finding without having to give the patient high concentrations of oxygen. And if you need to increase the PEEP, then that means to say that the patient has deteriorated. So therefore, this is incorrect. Okay. All right. So what are the drugs that are included in the management of patients with ARDS? Well, clients are usually given corticosteroids. And what is the function of steroids or corticosteroids in here? You remember that ARDS is the result of the inflammatory response. So steroids act to decrease inflammation in the respiratory tract. So this is going to include the use of solumedrol and prednisone. Patients with ARDS usually receive low molecular weight heparin or low-dose unfractionated heparin or other anticoagulants, and this is to prevent venous thromboembolism, unless of course, these agents are contraindicated. And then the other thing is enteral nutrition, and this is important in order to maintain good nitrogen metabolism, as well as stress ulcer prophylaxis. So usually the ones that we give for stress ulcer prophylaxis in the hospital is your Protonix or pantoprazole. I should have included that here. Which is usually given 40 milligrams per day. Right, of course, antibiotics as well as inhaled nitric oxide. You remember the function of nitrogen. And so when you give nitric oxide, this is going to cause arterial vasodilation in the pulmonary tract, and therefore it could improve perfusion in ventilated areas. And then, of course, neuromuscular blockers are usually given during the first 48 hours of ARDS, and this is going to leave the control of respirations to the ventilator. Because sometimes when patients are on a ventilator, they usually fight it off. And so therefore, by paralyzing them with neuromuscular blocker agents, you are going to have total control of with the ventilator. Okay. And the last piece, preventing complications. I've already mentioned DVT as a complication, and of course, ventilator-associated pneumonia as a complication. But it could also include pressure ulcers as well as poor nutrition. So we all know what those nursing interventions are going to be. All right, I'd like to see what your response here is, because it tests whether or not you understood what PEEP is. So a student asks you why the PEEP setting is at 10 millimeters of mercury on a patient with ARDS. Your response is? I got a response from Marcellus and Rhiannon. Thank you. And Jan, very good. So the correct answer is letter D, the setting of PEEP, which could range from 10 to 20 millimeters of mercury, by the way. I keep on saying mercury water, 10 to 20 millimeters of water. It helps to open the alveoli sac that usually are collapsed, especially during exhalation. And then, of course, we all are familiar with the VAP bundle, the ventilator-associated bundle. And of course, this includes interventions to prevent pneumonia. And what are these interventions? So I will highlight what are the important strategies as far as the VAP bundle is concerned. And the first thing is positioning. The position of the patient ought to be that the head of the bed should be elevated at an angle of 30 to 45 degrees. And this is essential in order to prevent the risk of aspiration. Okay? And of course, the other thing is that the patient should be awake sometimes and they should not be totally sedated. And this usually is accomplished by daily sedation interruption and a frequent assessment of the readiness of the patient to be extubated. And of course, the other thing is the use of subglottic secretion drainage. Now, if you notice that our endotracheal tubes now have two pigtails, and the first pigtail is the pilot balloon where you inflate the cuff. But the second one is connected to suction, because if we allow for secretions to be stagnant over in the subglottic area, what's going to happen is this could be a source of pneumonia. And so by having constant and continuous suction of this area, we're going to prevent the development of pneumonia. And then the other thing is that, of course, the chlorhexidine mouthwash. So usually we're going to have a chlorhexidine mouthwash once a day or twice a day. And of course, to brush the teeth every 12 hours. Okay. And lastly, there has been a change in the routine of changing ventilator circuits. We used to do it every day, and then they changed it to every other day. But now they have found out that actually every 7 days is really going to be sufficient, because the more you open this or break the integrity of the closed system, the more you're likely to have the chances of pneumonia developing. The other thing is, of course, your oral hygiene, and this includes the oral hygiene using a foam swab or a toothbrush, and then, of course, chlorhexidine solution right over here. And lastly, stress ulcer prophylaxis. As we have said, we could give proton pump inhibitors, H2 blockers, and antacids are not recommended by CDC. So these are the two things that we usually would use in preventing ventilator-associated pneumonia. And one last thing, remember when patients are on ventilators, we usually insert a feeding tube. And so the usual way in which we introduce the tube is through the nose. Well, we have found out that actually inserting it through the nose creates a environment of sinusitis, which means to say that you could therefore have an infection that will ultimately go into the lungs. And that's the reason why instead of nasal feeding tubes, we would rather use oral tubes. So we insert the tubes through the mouth, not through the nose. So we now go to the case study. And so for those of you who had the opportunity to answer them, you probably are already familiar with the case. But this is a case of a 78-year-old female admitted to the medical ICU in respiratory distress. So at 9 o'clock, the nurse's notes indicate that the client was admitted to the ICU in respiratory distress after a minimal response to high-flow oxygen for a pulse oximeter reading of 83% on room air. Crackles heard bilaterally in the lower lobes with diminished breath sounds in the right middle lobe. S1, S2 auscultated. Bowel sounds positive times 4 quadrants. Skin warm and dry, intact. Vital signs 99.8. Heart rate 110. Respiratory rate of 30. A blood pressure of 168/90. A pulse oximetry of 87% on 100% non-rebreather, and the pain is 0/10. So take a look at the laboratory results. And as you could see, there are some abnormalities over here. The ABG for one. And this one, 75, is okay, right? PCO2 of 51, this is also abnormal. This is also abnormal. And then, of course, this one is also abnormal. The platelets are okay. Your potassium is also okay. Your sodium is okay. Magnesium is okay. Your lactate is 4.5. It's high. And of course, gram-negative cocci, and the urine culture is pending. So remember what are abnormal? You have your ABG-pH, your PCO2, and your bicarb, as well as your WBC and your lactate levels. All right, so let's go to the next frame. Okay, so with this in mind, which 4 findings are most urgent? So we are now looking for 4 findings that are going to be the things that you need to focus on, most urgent. All right, can you share your thoughts? Mm-hmm. All right, if I were answering this one, most urgent, so some of you are saying that the WBC, the blood pressure is critical and so on. The lactate is critical. We're going to select the ones that have the most urgent need. And so what is the client presenting with? Symptoms of infection and respiratory failure, right? Why infection? Because of this, and respiratory, and this. And how about respiratory failure? This this, and of course, your pH. So right now we are looking at the problems associated with the infection or with the respirations. Which one takes priority? The infection or the, yes, the respirations, okay. So let's take a look at all the values that are going to be associated with the respiratory system. This pH of 7.2 is worrisome because you remember normal is 7.35 to 7.45. So 7.2 means to say that the patient is in acidosis. So this is something that is going to be concerning. Now, the other thing that's related to that is the PCO2. The PCO2 of 50, you remember that the normal PCO2 is anywhere from 35 to 45. So this manifests respiratory acidosis. And then, of course, it stands to reason that the respiratory rate is going to be severely abnormal. See, 30 breaths per minute. That's high. That's tachypnea. And of course, the last one is the pulse oximeter reading of 87%. All these show hypoxemia, and therefore they're going to be worrisome. All right. So in dealing with this question, again, I know that the WBC is abnormal, the lactate is abnormal, but again, weigh the two problems that are given here. One is a problem of infection, and the other one is a problem of airway or respirations. And the priority here is going to be anything that is related to the airway. Okay? All right. For each finding, choose to indicate if it is consistent with acute respiratory failure or pneumonia, and each finding may support more than one condition. However, each column must have at least one option. Okay, so whenever we have bilateral crackles, is this something that you would see in acute respiratory failure? And I would say that yes, you would, right? So where's my pen? I would say yes over here. Do you also have ralphs or crackles in pneumonia? Yes, okay, so I would check this as well. How about a pulse oximetry of 87 on 100%? This is refractory hypoxemia. And you remember that what do you call that? This could happen in either of these cases. You can see it in ARDS. You could also see it in pneumonia. How about a PCO2 of 51? This is going to be something that is a finding, in addition to pH of 7.2, respiratory acidosis. So this is consistent with respiratory failure. So usually you will not have these numbers in pneumonia. And a pH of 7.2, of course, this is severe acidosis, and therefore this is something that would be present in acute respiratory failure. Okay, so I would have answered it this way. An acute respiratory failure, you will see crackles as well as a pulse oximetry reading of 87%, despite the 100% FiO2, and the PCO2 of 51, and a pH of 7.2. Okay, so please stop me if you have any questions. So let's go now to the next question. what does the nurse determine is the priority for this client's care? I'd like to see what your answer is. Okay, so remember, infection versus airway. Which one is more important? The respirations, right? The airway. Okay, so what is the problem here, or what is the support? Intubation versus opening the airways with aerosol treatments. When do you use bronchodilators? You use bronchodilators in obstructive pulmonary disease or asthma, but this is not asthma. So what you need to do is going to have to intubate. So acute respiratory failure, remember, is characterized by the lung tissue's inability to oxygenate properly. And so the patient has had a poor response to supplemental oxygen and therefore now needs mechanical ventilation. So the respiratory failure was most likely caused by pneumonia. True, we need to treat pneumonia, but it should take, that should be the next intervention. All right. Okay, so that is the correct answer. And so let's go now to the next question. All right, so it is asking you now whether or not the intervention is indicated or not indicated. Because at 9:30, the client was intubated with number 6 endotracheal tube and was placed on assist control mechanical ventilation with a rate of 14, a PEEP of 5 millimeters of mercury, and an FiO2 of 60%. The vital signs are displayed in here, and the client is restless. So if the client is restless, should we give sedatives? Yes or no? Is the use of sedatives going to be indicated or not indicated? All right. So you remember what I said, in the first 24 hours, we usually even paralyze the patient. Why do we want to paralyze the patient? So that the mechanical ventilator can take total control. And so I would put a check mark here on indicated. How about repeat schedule suctioning every 2 hours? Should we have a routine suctioning? Meaning to say, should we have a particular time, or should we only do it as needed? Suctioning should always just be done as needed. Why is that? Okay, so let me illustrate. So if this is the airway, okay, I did a bad job in that. All right. So if this is the airway, what is in the dead space? These areas over here, from here to here, are what we call dead space, because what happens is that it does not participate in exchange of oxygen and carbon dioxide. So a patient actually will have oxygen over here all the time. Okay? So when you suction the patient unnecessarily, you're suctioning secretions, but you're also suctioning what? You're also suctioning oxygen. And therefore, it is a rule that there should not be any routine suctioning. So therefore, this is not indicated. Okay. How about amiodarone? What is amiodarone? What is amiodarone? Arone, anytime you see a suffix arone, it is an anti-arrhythmic agent, and therefore that's not indicated as well. All right. How about administer antibiotics? Yes. All right. Because this is the one that precipitated the ARDS. Position supine. Yes or no? No. Okay. Prone positioning if possible, right? Okay. And obtain an electrocardiogram? Yes. Okay. You would want an ECG whenever a patient is critically ill. What we are concerned about is the possibility of complications, which might include a myocardial infarction. And therefore, ECG is going to be imperative, right? So this is the way in which you needed to approach this question. So let's take a look at the last one. That you have three orders. You have orders. You now have to choose the three orders that you should implement first. Okay. So the patient was just intubated, right? Very good. Call for x-ray. You need to have an x-ray because the patient was just intubated. So we need to do this. That's one. Okay. And let's see. Rhiannon said we are going to do an ECG. I mean, an IV. Yeah, I agree. You need to give medications to this patient. What medications are you going to give? What medication, I should say, should you give to the patient? Why did they order this midazolam? The patient was restless, right? So sedation should be given to decrease the agitation. So letter C is correct. All the others could come next, but we're asked for the three orders that the nurse must implement first. Okay? And let's go to the next one. So it's now 10 o'clock and the chest x-ray was obtained. The IV was placed and midazolam was given. The ECG shows sinus tachycardia and the vital signs 99.8, heart rate 100, respirations 14, blood pressure 150, FiO2 60%, drowsy, -1 sedation scale. So let's see where this is leading us to. Okay, so the nurse reassesses the client at 10 o'clock and compares the findings to 9:30. For each finding, we're going to click to specify if the finding indicates that the client's status is improved, declined, or is unchanged. So let's take a look at the heart rate. What was the heart rate before? The heart rate before was 110, and now it is 100. So is this an improvement, a decline, or unchanged? What should we answer? Improve. Okay, very good. How about the temperature? The temperature at 10 o'clock was 99.8. And now it's 99.8. So I don't think there is any doubt that this is unchanged. Okay. And how about the respiratory rate? The respiratory rate was 14, and now the respiratory rate is 14. So again, it is unchanged. Let's take a look at the blood pressure. The blood pressure was 180 over 90, and now the blood pressure is 150 over 70. Okay, Rhiannon is ahead. Improved, she says, and I agree. Okay. The patient, whenever you are stressed, the blood pressure increases. And as you resolve the stress, you obviously decrease the blood pressure. The pulse oximetry, let's see, 96 over here and 93 over here. Uh-oh. Decline, very good. And the last one is agitation. It says the client is restless at 9:30, and the patient now is -1, drowsy on the sedation scale. So this obviously has improved. Okay. So that ends my presentation, ladies and gentlemen, or ladies. I hope that you have gotten a sense on how to deal with the case studies when presented in the Nclex. I certainly enjoyed our interaction, despite the fact that you were just interacting with me through the chat, but nonetheless, it has been my pleasure. It always is my interest in helping future nurses to hurdle the Nclex exam. So I wish you well, and I hope that you will attend again tomorrow for another case study. Okay? So thank you and have a great night. We'll see you at 6 o'clock tomorrow. Thank you.